Okay. All right. Welcome to Much Ado About Clozapine. Everybody knows me, I think, except for the medical students. I'm the clinical psychiatric pharmacist for U of L Health, and I cover 3 North and 12 GS, a geriatric psych unit for Peace. And- oh, okay. I don't have any disclosures. I just skipped through the disclosure slide. I don't have any financial disclosures to talk about. We will be talking about some off-label uses of clozapine during this conversation. And the goals of this discussion are basically to learn how and when to use clozapine safely and effectively, and also develop a good understanding of the Clozapine REMS program. So how does clozapine work? Clozapine has activity on nearly 24 different receptors, and understanding the mechanism of action of clozapine is still, quote, in development. However, the antipsychotic effect of clozapine is thought to be due to potent D1 receptor agonism, and then 5-HT2A and 5-HT2C receptor antagonism. Something to note is that it's a weak D2 receptor agonist. I'm sorry, weak D2 receptor agonist. And it like quickly dissolutes from the D2 receptors. So like this low activity of D2 in the striatal region is thought to explain why clozapine has a very low incidence of movement disorders in comparison to the other antipsychotics. The antagonism of alpha-1, H1, and M1 explains a lot of the side effects that we're going to talk about with clozapine and some of the pharmacodynamic interactions that we have to be aware of. So while we're talking about all these receptor activity, we're going to kind of get into also the pharmacokinetic interactions of clozapine. Clozapine has activity. It has several active metabolites, as well as activity at nearly 24 different types of receptors. So understanding the mechanism of action, I'm sorry, got the wrong thing. So it has 3A4 metabolism is the primary route of metabolism for clozapine. So we've got to avoid 3A4 inducers and inhibitors. Can you all think of any 3A4 inducers that come to mind? Anybody?
Tegretol.
Tegretol, yes, yeah. Any others that come to mind? Okay, so we need to worry about our old seizure medicines. So carbamazepine, phenobarbital, phenytoin, and even oxcarbazepine. Rifampin can be a 3A4 inducer, corticosteroids, and even St. John's wort. So you want to try to avoid those medications. Those are some significant interactions with clozapine that would pretty much render it useless to give it with those other medications. Can anybody think of 3A4 inhibitors that we need to think about? Anyone? Anyone? Courtney, can you think of a 3A4 inhibitor? Yeah, so our antifungals, so we've got fluconazole, itraconazole, ketoconazole, maconazole. Grapefruit juice is a 3A4 inhibitor. Macrolide antibiotics, so your clarithromycin, erythromycin, telithromycin, your antivirals, your ritonavir, nalfenavir, and then even your calcium channel blockers, diltiazem, verapamil, and amiodarone. So all of those would be 3A4 inhibitors that would increase the effect of the clozapine. So you would need to do a dose adjustment and dose very cautiously. I would recommend if you're on a 3A4 inhibitor that you titrate your dose very slowly because you're more likely to have side effects. So clozapine is also around 15% metabolized by CYP1A2 enzymes. The CYP1A2 inhibitors, can anybody think of those?
Cigarette smoke.
So that is an inducer, a CYP1A2 inducer. So it will significantly decrease the effect of your clozapine. So yeah, as far as CYP1A2 inhibitors, we've got ciprofloxacin, fluvoxamine, caffeine, and estrogens are our primary ones. So if your patient's on an oral birth control, or if they drink a lot of caffeine, then you may find that they're going to have increased risk of side effects from the clozapine. And so, with the cigarette smoke, we have a lot of patients that are not allowed to smoke in the hospital. We start clozapine and then we discharge them. They start smoking. And so then their clozapine doesn't work as well. Sometimes they end up back in the hospital. So it's important to be aware of these pharmacokinetic interactions and manage them as well as you can, kind of anticipate changes and address any medication changes. And so there's also some 2D6 metabolism that doesn't significantly affect the clozapine levels, but it's something to be aware of. Also, genetic variability can play a role. So people of Asian descent may have reduced CYP1A2 metabolism, so they may be more sensitive to your clozapine therapy. The people of European and sub-Saharan African descent will have higher CYP1A2 metabolism, so they may require higher doses, especially people of sub-Saharan African descent. Okay, so in addition to the pharmacokinetic interactions, there's a lot of pharmacodynamic interactions with clozapine that we need to be aware of. And QT prolongation, I talk about this one a lot with all of you. So patients that have a baseline prolonged QT, or they're on concurrent QT prolonging meds, such as like Reglan, mirtazapine, citalopram, tricyclic antidepressants, stimulants, our VMAT2 inhibitors, our fluoroquinolone antibiotics, antipsychotics, macrolide antibiotics, like all of these can further prolong the QT. So they're at higher risk for arrhythmia. We'd want to monitor the heart rate very closely and monitor the EKG, follow up with an EKG with our dose changes. Anti-acetylcholinesterase inhibitors, clozapine can counteract the effect of these and vice versa. Anticholinergic medications, so when you add clozapine and they're already on anticholinergic meds, you've got an increased risk for urinary retention, constipation, ileus, dry mouth, confusion. Seizure lowering threshold. Can you all think of any medications that decrease the seizure threshold?
Methamphetamine.
Go ahead.
Amphetamines.
Yes, amphetamines, all, and then we also have to worry about bupropion. That's a common one that we use, but any kind of stimulant, tricyclic antidepressants, or other antipsychotics will lower the seizure threshold. So if you add on clozapine, your patient's at a little bit higher risk of seizures. So monitor carefully and decrease that risk as much as you can by removing those precipitating medications. CNS depressants, if they're already on opioids or benzos or barbiturates, they're going to be further sedated when we add the clozapine. And even when we have a sedating antipsychotic, we may also have increased CNS depression with adding clozapine. Antihypertensives, so there's a risk of orthostasis with clozapine. If they're already on blood pressure meds, their blood pressure could get too low. They could get dizzy and be a fall risk. And then clozapine can counteract the effect of anti-Parkinson agents and dopamine agonists such as levodopa, pramipexole, ropinirole, rotigotine, and vice versa. Myelosuppressive meds. Can you all think of some examples of myelosuppressive meds that we might need to worry about?
Tegretol.
Very good. Yeah, Tegretol comes up a lot. And phenytoin is another one. Indomethacin, methimazole, if they're on chemotherapy or if they're on immunosuppressants, maybe you have a transplant patient, you'll need to monitor that ANC very closely because they're at higher risk for the myelosuppression, the neutropenia. And then we do have some increased risk for serotonin syndrome with our other serotonergic medications. Okay, so we've kind of gone through some interactions and precautions. When might clozapine be a good choice for your patient? When have you used clozapine in your practice? Anybody want to share examples of when you've used clozapine? Okay.
Well, treatment-resistant schizophrenia and sometimes treatment-resistant bipolar as well.
Yeah. And so those are the primary indications that you're going to most commonly see clozapine started for your patient is the treatment resistance, and then also the suicidal behavior in schizophrenia and schizoaffective disorder, and the treatment resistant bipolar. And then also some of our dementia patients that have severe or refractory agitation, aggression, and psychosis associated with the dementia, you might want to try clozapine for them. Psychosis and Parkinson's disease. And then some like more obscure indications that you might try clozapine for is psychogenic polydipsia, refractory depression with psychosis, and refractory autistic spectrum disorder related aggressive behaviors. So you decide that clozapine is the right fit for your patient. What's the next step? Well, you're going to make sure that you and the patient and the pharmacy are all enrolled in the clozapine REMS program. And you're going to do baseline monitoring. So you're going to get your EKG, the weight, height, BMI. We don't do a waist circumference at U of L, but it's recommended. A complete blood count with differential. So you want an absolute neutrophil count that's greater than 1,500 for the general population or greater than 1,000 for patients with benign familial neutropenia or BFN. You also want to get a baseline comprehensive metabolic panel, a hemoglobin A1C, fasting lipid, thyroid stimulating hormone, maybe get the whole thyroid panel, mental status, and vital signs. So you do the baseline. Let's get into the clozapine REMS program. Is anybody familiar with the clozapine REMS program? Is anybody registered with the clozapine REMS program or enrolled a patient?
Enrolled a patient.
You did?
Yeah.
Okay. All right. So I'll show you some of the screens that you'll see as a provider, and I'll also show you what the pharmacy sees from their end. So what is the clozapine REMS? Does anybody know what REMS stands for? Okay. It's a risk evaluation and mitigation strategy. The Food and Drug Administration set up the clozapine REMS program to manage the adverse effect of severe neutropenia. They wanted to make clozapine available to healthcare practitioners in the United States, but they wanted to do it safely and have early detection of that neutropenia before it became fatal. It was implemented in 2008. It's currently a shared REMS system, meaning that multiple manufacturers participate in the same system. Originally, the the clozapine REMS was kind of siloed by manufacturer. So you had to log into the manufacturer that you were dispensing and enroll the patient in that program. But now we have, fortunately, a shared system where we log into one program. It does require frequent ANC monitoring, the absolute neutrophil count, and reporting. And here's the current website. It's newclozapinerems.com. And we'll get on to, so to register a prescriber, you're going to go to the home page and you're going to click on the bottom right-hand corner where it says Certify Prescriber. Then you're going to prepare for a small quiz. This document here, Clozapine and the Risk of Neutropenia, a guide for healthcare providers, that will tell you everything you need to know. It's about a like 12 to 15 page document, just telling you like how to use Clozapine and what to do if your patient develops neutropenia, and then exceptions to the rules and things like that. It really doesn't take long to skim through it. And then after that, you're going to take the knowledge assessment for prescribers. Down in the bottom, you can click online or you can print it out, fill it out, and fax it in. So just complete the knowledge assessment. Like I said, you can fax it or complete it online. And then after you've done this knowledge assessment for prescribers, you're going to complete the prescriber enrollment form. You can do that online or you can fill it out and fax it. This is the information that's needed on the prescriber enrollment form. So you need your first and last name, the NPI or DEA number, email address, credentials, the practice name, practice address, phone number, fax number, and then preferred method of contact and the signature and date. It's important that the Clozapine REMS program is able to reach you, to contact you, because if your patient is on Clozapine and if there's ever an adverse drug reaction reported, they have to follow up with you for additional information about how it was managed and what happened to the patient, if there were any other medications that could have contributed, what monitoring was done, was the patient hospitalized, was there a bad outcome, did the patient, did the condition resolve? They need all of those details. So they will follow up with you. Unfortunately, they often follow up a couple of months down the road. So you may be like, which patient is this? But you can call them and they can give you that information because they're just going to give you like initials. And sometimes it's a little challenging to remember what happened a few months ago. So after you've enrolled, then your next step is to enroll your patient. You need the first and last name of your patient, the gender, the date of birth, the race, ethnicity. You need to the date and the result of their most recent ANC value. It's important to note if your ANC was not done in the past month, you can't enroll a patient. There's a roadblock to that, and the Clozapine REMS program won't let them be enrolled. So make sure you have a current ANC before you start all of this. The phone number, email, and address, zip code are not required. They're there in case you have a patient who has stable housing. It helps them for patient identification, but it's not required because the REMS program understands the nature that a lot of our patients are unhoused. So good news is you can phone a friend for this. You can assign a designee to help you keep up with the REMS requirements. The prescriber can enroll a designee online or by faxing a printed enrollment form. They will need the designee name, phone number, email address, and prescriber's name and NPI. The designee can enroll patients in the Clozapine REMS program on behalf of that prescriber, and they can report ANC values and update the patient status forms on the prescriber's behalf. So Those are the three roles that a designee can do. I am a designee for most of the inpatient psychiatrist at U of L and at Jewish Hospital. So I can enroll most of the patients. There's no other pharmacist that has designee status because they have the burden of having to use their U of L email accounts for the pharmacist role. And I have an extra email account set up to support the designee role. So none of the other pharmacists know how to enroll and they don't have privileges. It's just too much to ask for the staff pharmacist to keep up with that. And a prescriber can have more than one designee. So if you work in a clinic and you've got some office staff that can help you with the ANC reporting and the compliance with the clozapine, you can designate more than one of them as your designee. So there are a few things that the clozapine REMS designee is not able to do. So if your patient has benign familial neutropenia, so they've got an ANC that's below 1,500, and there's a history of them having a consistently low ANC, and you've established that they have the BFN, the designee cannot justify continuing the clozapine, only the provider can. If the patient becomes neutropenic, only the provider can justify continuation of treatment. They can, submit a rationale for treatment in light of the neutropenia. Hospice patients don't have to adhere to the weekly monitoring of ANC. So only a provider can establish a patient as a hospice patient in the REMS program. And then if a patient's not compliant with labs, the REMS program does offer some grace for the provider to justify continued use. Maybe the patient was in, a life-threatening situation off of the clozapine. They're finally stabilized, but they won't allow the lab draws. A provider can justify that by submitting a form to the clozapine REMS program, but the designee cannot do any of these functions. Okay, so this is what a pharmacist sees in the clozapine REMS program. So when you enter an inpatient order for clozapine or you send a prescription, the pharmacist will log on to the clozapine REMS program and they will click on this obtain a patient RDA, which is an RDA is a REMS dispense authorization. So basically the pharmacist is asking the clozapine REMS program for permission to dispense clozapine. If the certain requirements are not met, then the pharmacist gets an error message and they will not get that RDA code. So the pharmacist, will, for them, I guess, let me give you a little history too. We also have to do a clozapine guide, and then we do a knowledge assessment, then we enroll, and then we can enroll other pharmacists in the pharmacy. We also have to certify the pharmacy with a wholesaler. The wholesaler has to get permission from the clozapine REMS program that we've met all of that criteria, and then they'll allow us to purchase it from special wholesalers. Pharmacists can also submit an ANC value. It's important to note we can submit the weekly ANC values, but it doesn't take the place of the monthly patient status form that the provider is required to submit. So the patient status form may still be overdue, even though the ANC values have been reported by a pharmacist. Sometimes there's a little discrepancy there. So this is what the pharmacist sees when they're trying to obtain a REMS dispense authorization. They're going to do the patient's first and last name and date of birth, or they will enter the REMS patient ID if that's available, and then they will search for the patient. Here's an example of an a situation where we were not granted the REMS dispense authorization. This patient had not been enrolled. So we had to go back to the provider and ask them to enroll the patient in the Clozapine REMS program before we could proceed. You'll notice in the bottom left-hand corner, there's an option to request transition dispense rationale. That is set up only to continue therapy, so it's not interrupted until the discrepancies can be resolved. So it doesn't fix any of the discrepancies. It's not a bypass. It's just kind of a temporary Band-Aid that we can obtain, but it is not for new initiations of clozapine, only so that somebody doesn't miss a clozapine dose. Okay. So any questions about the REMS program at all? Any questions?
No, that was helpful. Thank you.
Okay, you're welcome. All right, we'll get a little bit into dosing and monitoring of clozapine. So initial dosing is generally 12.5 to 25 milligrams daily. And you generally titrate slowly by 25 to 50 milligrams per day. You would increase the dose in intervals of 1 to 3 days. And it's got a wide dosing range. Some of your patients may respond to doses as low as 100 milligrams a day, and some may require dosing as high as 900 milligrams daily, divided into 2 or 3 doses. If dosing is interrupted for more than 48 hours, the titration has to be restarted. So you have to go back to your 12.5 milligrams or 25 milligrams daily if they've been off of it for more than 2 days. So we titrate the dose slowly to help reduce the risk of serious adverse effects. And then we increase the dose only as your patient tolerates it. So, there are quite a few patients that don't tolerate clozapine well, and sometimes you can't even increase the dose every 3 days. Sometimes you have to slow it down. Also note in the dosing, patients with dementia tend to require doses anywhere from 25 to 100 milligrams. So they're going to get much, much lower doses than your antipsychotic, typical antipsychotic dosing. And then another caveat is when you're retitrating, you can go a little bit faster for patients that have already tolerated clozapine. So maybe you can increase the dose every day. But you do have to still do the retitration because there's an increased risk for myocarditis if we don't retitrate. Like if the patient comes in the hospital and they were previously on clozapine 300 milligrams at night, but they've been off of it for 2 weeks and we restart that 300 milligrams at night, they're at higher risk for myocarditis. So to avoid that risk or minimize it, we want to retitrate. Okay. So recommended clozapine monitoring, we have to meet the requirements of the REMS program. We have to do weekly ANC monitoring for 6 months. And then the next 6 months, months 7 to 12, it's every other week. And then after that, if they've been stable, no significant changes in the ANC, then you can go to monthly monitoring thereafter. It's recommended to do a CRP and troponin every 4 weeks. We're monitoring for myocarditis and any kind of inflammatory condition. So we want to detect it as early as possible so that we can slow down the clozapine titration and make other interventions as needed before it gets into a life-threatening condition. One thing about the ANC that I didn't talk about, if the ANC for the general population, I've got somebody doesn't have benign familial neutropenia, if it falls below 1,500, you're going to need to monitor that ANC 3 times a week until it rises above 1,500, until it stabilizes. If your patient has benign familial neutropenia, then you wait until the ANC falls below 1,000, and then you monitor every 3 times a week until it comes back above that above the 1,000 level. For vitals, what kind of changes in vitals are we looking for with clozapine that might be signs of side effects? Anybody? Mueller?
Tachycardia and hypotension, especially orthostatic ones.
Mm-hmm. Yeah, and you may see some respiratory depression, especially with some of the older geriatric patients, may have shortness of breath. Fever may show up, and then sometimes you may get bradycardia. So if there are changes to the vitals, you're going to want to step up the monitoring, check their O2 saturation, maybe follow up with an EKG. So bowel movements, we want to make sure that our patients on clozapine are having regular bowel movements, at least one spontaneous bowel movement every other day. If not, you want to be very proactive about ordering your PRN constipation meds and possibly even a daily or every other day scheduled constipation med, because there is a high incidence of ileus with patients on clozapine. So be very very diligent with the bowel monitoring. The weight, BMI, waist circumference is recommended to be done monthly. And then if any changes arise, any concerns, you're going to want to get an EKG, prolactin, CMP, clozapine level, lipid panel, hemoglobin A1C, anytime that you're concerned and you want to investigate further. So if you're concerned about metabolic syndrome, if you're concerned about changes in the heart rate, if you're concerned about potential liver pain, you want to maybe get a CMP. The clozapine level, we don't actually routinely monitor that unless we think the patient is having side effects or maybe they're not responding to the clozapine. That gives us another piece to kind of guide the dosing. And also assess for involuntary movements that can occur even though the risk is low. Okay, so here are some major clozapine adverse effects. So the neutropenia is not the only life-threatening adverse effect that we are concerned about. Your patient could be at risk for heart disease, so myocarditis, acute myocardial infarction, arrhythmia, deep vein thrombosis, pericarditis. They may develop pneumonia. Aspiration pneumonia is not uncommon with our patients with poor swallow. Maybe they've been on antipsychotics or neuroleptics for many, many years, or they're geriatric patients have a higher risk for aspiration pneumonia. Inflammatory reactions such as hepatitis, nephritis, pancreatitis has been known to occur with clozapine therapy. Seizures, we talked about that earlier. Hepatotoxicity has been known to happen. These first 6 adverse effects are more likely to happen in the first 6, like the first month of therapy, first 4 to 6 weeks. So that's why we are pretty aggressive with our monitoring initially while we're titrating the dose. Ileus has been known to happen, and orthostatic hypotension falls. Those can happen anytime during the clozapine therapy. It could happen years down the road. But like I said, the first 6 are more likely to happen in the first month of introducing and titrating clozapine. So it's important that we monitor early so that we can have early detection and implement precautions when possible in order to reduce the risk of all of these serious complications. Okay, before we go to the next slide, does anybody have any, has anybody experienced major clozapine adverse effects for any of your patients? Have you had anything you want to share about that? No. Okay. Has anybody seen minor adverse effects with clozapine?
I know, just going back to major, I know that there was that patient on 3 North that I believe he had clozapine-induced myocarditis and ended up in the ICU.
Yeah, yeah, we've had 1 or 2 myocarditis cases on 3 North since I've been there. And we've had a couple of ileuses. Last summer we had, I think, 3 that we had. So yeah, we try to be aggressive with our bowel regimens for those, and we have had some falls. So yeah, I don't recall seeing pneumonia here at 3 North, but I used to work at the Hazelwood Center and actually had 2 patients every time we started any antipsychotic, they developed aspiration pneumonia and clozapine included. So, and we've had neutropenia. I know Dr. Malik likes to add the lithium, and that's a reasonable measure to try to, when you do start having the neutropenia. From what I've read, there aren't really adverse effects other than just the side effects from the lithium, but usually a low dose of lithium may allow your patient to continue on the clozapine. But the concerns for myocarditis, that's generally a reason to stop your clozapine until you can figure that out, until it resolves. We did have a patient that we suspected had myocarditis, and we reintroduced the clozapine, and he tolerated it, but we've had another one that didn't tolerate the reintroduction of the clozapine. So you never know how it's going to proceed. Thank you for sharing. So any other comments about major? We'll go on to the lower acuity adverse effects of clozapine. I know a lot of you have seen the sialorrhea. For that, I typically recommend using atropine eye drops, just a couple of drops under the tongue, rather than using the glycopyrrolate or hyoscamine oral, because you've got increased risk for ileus and constipation if you give them an oral medication versus just a local sublingual. Another option is the ipratropium bromide nebulizer solution. You can put a couple of drops under the tongue there, up, a couple of times a day, and that would usually help with the sialorrhea. Xerostomia or dry mouth. You can give Biotine mouth coat. Another brand is Entertainer's Secret. Those are sorbitol or xylitol over-the-counter mouth moisturizers. So you can use those. You can generally use them up to 4 times a day. And then we talked about constipation, hyperlipidemia, weight gain, hyperglycemia, diabetes. So you'll definitely, you can refer to primary care, or you can start medications to help manage those conditions. If weight gain does occur, I recommend getting a fasting lipid and a hemoglobin A1C just to detect if there are some other metabolic interventions are needed. For GERD, for gastroesophageal reflux, I recommend avoid the proton pump inhibitors when your patient's on clozapine because of the interactions. The proton pump inhibitors can decrease the clozapine concentrations. So I would steer you towards famotidine, an H2 antagonist, for managing the GERD symptoms. Dizziness and sedation, those will usually resolve after a couple of weeks of consistent dosing of clozapine. If it's still problematic or if it's impairing your patient's ADLs, you may need a dose reduction of the clozapine. And this may warrant monitoring the clozapine levels just to see, or maybe they're a slow metabolizer and their clozapine levels could be too high. For sun sensitivity, you want to counsel really any of your patients that are on an antipsychotic, counsel them to use sunscreen, at least a 30 SPF or higher, and they're going to have heat intolerance. They're not going to be able to cool their bodies off as well as somebody who's not on these medications. So they're going to need to stay in shaded, cool areas, which can be a challenge for some of our unhoused population. rash is usually benign with clozapine, but it could potentially be drug reaction with eosinophilia and systemic symptoms, or it could be Stevens-Johnson syndrome. So, counsel your patient if they develop a rash to get it checked out by a healthcare provider. And then urinary retention can sometimes be a problem, especially with our older male population. Okay. So, any other side effects that you've seen for clozapine that's not on this list? Does anybody have any questions about how to manage these side effects? No, okay. All right, in summary, clozapine can be a great treatment option for your challenging and/or treatment-resistant patients. It works well. We don't want you to be afraid of it, but we want you to proceed with caution. Some psychiatrists are afraid of it because of the burden or because of the serious side effects. But as we've talked, there are ways to manage those side effects and to decrease the risk of life-threatening complications. And, always remember that the provider, the patient, and the pharmacy are all required to be enrolled in the clozapine REMS program. And perform a thorough interaction screening. You can get a pharmacist to help you with that, and baseline monitoring, and then also continue your routine clozapine monitoring to thoroughly and continually assess for potential adverse effects. It's important when you detect a potential adverse effect, you slow things down and make sure that it's not getting worse, so that you can manage safely. So you want to start clozapine dosing low always and titrate slowly. And remember to repeat that titration if your patient has been off of the clozapine for more than 2 days. Any questions?
Thank you, Leigh, very much for your presentation. I had a question about when the ANC drops and we use lithium to augment and increase the white blood count in general. Is there any kind of research or literature like related to that?
I have seen it. It's a couple of years ago since I looked at it, because I hadn't seen it done until Dr. Al-Malik was doing it. So I wanted to make sure that we had some literature, and I have seen some studies where it's been done safely. It's not, there's no guidelines on it, but typically the dosing's like around 300 is enough to get the ANC back up. Because I wanted to make sure that we weren't just kind of developing, replicating weak red blood cells that wouldn't fully develop into a full immune response. But it seems like the immune response is the same with the lithium and not. So
Yeah, I think
it's
lithium
very
just
off-label
increases,
use.
right. It just like increases the transmigration of the cells themselves into the blood from the bone marrow. So it's kind of like a fake increase, but the cells are still there. It's not just more cells, it's just they're more in the blood rather than being stored.
Yeah.
Do you think, have you seen like any cases where that didn't work, or maybe people on 3 North that were hospitalized?
On 3 North, I think we've done it probably 8 or 9 times in my 7 years there. And it's been fine. The patient responded well and no problems with giving it. So, but I haven't really seen literature like as far as years or anything like that. It was very short term. The research that I've seen was very short duration. Does anybody have any questions about clozapine